Hi everyone, my name is Nicola McDonald. I'm a child and family psychologist in Christchurch, and I have been asked to speak around working with kids and families when there's toileting difficulties present. And I really appreciate the opportunity. I wish we were having a Zoom conversation with each other so that we could ask questions and interact, but hopefully this will still be valuable to you. To give you a bit of an idea about my professional background, I've been a child and family psychologist for about 10 years now. I initially was born in Invercargill and have worked my way up the South Island, going to Dunedin for my undergraduate study and then up to Canterbury for my postgraduate study. I have a few roles at the moment. This one that I'm talking to you from is I do a small amount of private practice. I also hold a lecturing position at the University of Canterbury, and I also do some work in the paediatric department at Christchurch Hospital. And so I guess I'm bringing my understanding and my practice learnings from all of those places to speak with you today around overall tips and tricks for working with kids and families with toileting difficulties. As we all know, it's incredibly difficult work, and so I wanted to share what I have learned with you as best I can. In terms of an outline for today, this is roughly where we're going. I'm expecting that we'll have about an hour, and we want to talk about how toileting works in the New Zealand context. I want to talk to you about some myths about the work that we do. I want to talk to you about the comorbidities that are often present for young people who are in this position, and the family impacts and factors that might be at play in toileting situations. I also want to talk about the emotional punch that toileting really seems to pack when it comes to families and also the people working with them. And we'll spend a lot of time talking about treatment and how I work with families in this forum. I want to talk through some case studies. They're conglomerate cases. They don't come from particular people that I've worked with, but just to go through and illustrate some of the points that have become important to me and how I work with toileting as a psychologist. I really want to start by being really clear that I know that the people that will be watching this webinar are people who have lots of experience working with kids with toileting difficulties. I don't have a silver bullet. I wish I did, but I don't. And a lot of the things we discuss today will be things that you're already aware of. However, I just want to, offer the things that I have learned so far in the hopes that here and there you'll pick up some things that might be useful for you in your practice. So that's where we're going today. To start us off, toileting problems in New Zealand, we know that overall across the globe, people have difficulty with their toileting, and we know that on the whole toilet training is occurring later worldwide now than it used to, say 40, 50, 60 years ago. There are a lot of theories around why that might be, and one of them is around the invention of disposable diapers. Is it that as parents have, both wanted to work and had, more time spending on their work, is it that actually toilet training has inevitably had to happen later in a child's development? No one really knows. It's an interesting thing to think about. What we know in New Zealand is that about 10% of our kids aren't toilet trained at the age of 5, and that's a stat from Plunkett. When you think about it, it's pretty high, and I would hazard a guess that probably in Christchurch, where I'm based, we find that is even slightly higher. We know that in terms of enuresis, 3.5% of kids wet during the day, and 2/3 of the kids who wet during the day also wet at night. So we see that relationship between diurnal and nocturnal wetting. And we also know that about 10 to 15% of kids who wet become dry each year. So our understanding of this problem is that it is a big problem in New Zealand and across the world. It is a problem that generally resolves over time, but can take a long time to do so. And so I suppose often the referrals that yourselves and I and me are getting is around when that's not resolving as quickly as people would like, and that's causing impact on an individual and their family's functioning. In terms of nocturnal enuresis, we know that it's the second most common chronic childhood disorder in New Zealand. This is a big problem, it's a prevalent problem, and one that pops up in paediatric departments incredibly frequently. We know that as people get older, the prevalence decreases. You can see that there. We're dropping from 15% for 5-year-olds down to about 1% of adults. And as you'll know, we generally treat enuresis from the age of 7 onwards, which is the age at which we would expect that pathway will have developed effectively. Encopresis, functional encopresis, is a really common, undertreated and often over-interpreted toileting problem in kids. The reason I plonk this quote in here is because I think that for a very long time, the idea that a child is pooing their pants has been one that has made psychologists and other professionals go, I wonder what's going on with that child. And I think that Freud has a lot to answer for there. A lot of his thoughts around toileting and how that develops and what it might mean if you don't poo in the right place, all those kinds of things, have led us to sometimes overinterpret what might be happening for a young person who experiences encopresis. We know there's a prevalence between 1 and 4% of kids have poo problems, but we know that only about 1/3 of those seek treatment. So we know that out there in the world, there are 2/3, there are 60% more of these kids than we are seeing. And we know that the vast majority of the time, kids who have encopresis are also experiencing constipation and are developmentally normal. Most of the time, constipation is present. We know that 25% of gastro cases are there because of constipation, and it's one of the most common PEDS presentations that occurs across the world. And we know that for the 5% that don't have constipation, we know that treatment can be really, really difficult in those cases. You'll know as well as I do that the ratio of boys to girls is about 2 to 1. We're twice as likely to see boys coming through our clinic than girls for encopresis. And you'll also know that there's an incredible hereditary component with toileting difficulties. We know that it is far, far, far more likely that a child will have difficulties with toileting if a first-degree relative has had that as well. The reason I pop that in, I know we all know it, but is around the fact that when you're working with a family who have a difficulty around toileting problem, there's a reasonable chance that there might be someone else in the family who's been there before. And I suppose I always hold that respectfully, thinking about when I'm talking with young people and their families around toileting problems, understanding that actually some of the parents, for example, aunts, uncles, might be coming from a place of knowledge around these difficulties that they wish they didn't have, and so trying to use that to our advantage and be really respectful of it. Another really important thing, which I'm sure you're all thinking about in your world, is whether or not the toileting difficulty that the child is experiencing is a primary one, so the child's never achieved continence for more than 6 months, or a secondary one where they've been continent for a period of time, but for some reason, for whatever reason, that has gone backwards. And I think that's a really important thing to consider, because how we treat it does differ according to whether it's a primary or a secondary difficulty. As a psychologist, secondary difficulties do tend to prick my ears up because often the toileting difficulty in that situation is more a symptom of the difficulties than the difficulty itself. And so making that distinction is really important. Pathways in New Zealand for kids with toileting, you'll all have seen hospital health pathways, but generally what happens is kids are seen by their GP, maybe it's picked up in a before school check, something like that. Generally it's managed at a GP level. From time to time a paediatrician might get involved as well. You'll know that we need to make sure we've got a really sound medical assessment first to make sure there's not other things contributing to these difficulties. And as you'll know, you guys probably represent the big players in managing toileting in New Zealand, certainly in Christchurch. PHMs, nurse ward and NGOs tend to be at the front line of that. And there's also a group of kids who are seen through paediatrics and through the paediatric consult liaison service at the hospital. I've put a picture of a sparkly unicorn in this PowerPoint. The reason for that is, when I started out doing this work, I had this longing and belief that maybe if I got a case for toileting problems, I'd just be working with toileting problems. In my opinion, and the opinion of some of my colleagues, the great myth around continence work is that all you've got to do is fix the pee and poo. And so far in my experience, I have learned that that is a complete myth. I'm yet to come across in my field very many simple just toileting problems that aren't complicated by things like anxiety, behaviour problems, low mood, maybe parental mental health, maybe learning difficulties, maybe an undiagnosed intellectual disability, all those kind of things, ASD, heaps of different things often travel alongside toileting difficulties. And so I've had to let go of my sparkly unicorn and let go of my dream of simple, non-complex toileting referrals, because so far I've not come across any of them. Psychological comorbidities are really, really prevalent in this population. We know that they have a much higher rate of psychological difficulties than kids who don't have toileting problems. So about a third of kids who have overnight pee problems, and 20 to 40% of kids who wet themselves during the day have got other psychological difficulties that could meet diagnostic criteria. For nocturnal enuresis, we know that externalizing difficulties, particularly ADHD, are most common. And I suppose if you think about that, it kind of makes a lot of sense. What you've got is a young person who's having trouble, noticing and receiving signals from their bodies. And if you think about that, ADHD is going to be something that really gets in there and makes that really challenging. The bottom one in the slide is really important too. We know that up to half of kids with encopresis have other psychological difficulties. And for that population, they're equally likely to have an internalizing difficulty, like a mood disorder or anxiety problems, and an externalizing disability, conduct disorder, oppositional defiance disorder, behavior problems, ADHD. And I think it's really useful. Understanding this has helped me understand why I'm still waiting for my sparkly unicorn, and I might be for quite some time, because a lot of these kids are impacted by lots of other difficulties beyond their toileting. And I think it's really important for us to hold that in mind. I think often if there's a family that you're working with and you can't get any traction and things are really, really challenging, it's really worthwhile to stop and take a bit of a look and go, okay, actually beyond the toileting problem, what else is a problem for this whānau? What else is getting in the way? What are the barriers here? Because you may well find some. I should take a moment here to say that actually these difficulties, there's no guarantee. There's no guarantee that just because you've got problems with wetting your pants, you also have a different difficulty. But I think there's enough research that would suggest that that is more likely for these kids than other kids, that we need to keep our eyes and ears out for it. So in terms of family factors, I'd imagine all of us in our work have encountered extremely complex family situations that are occurring for these young people with toileting difficulties. And I think, it's really important to stop and take a minute to think about why toileting difficulties might be a huge problem for a child and their family. If we think about impacts on the child themselves, we know that having toileting difficulties can make social situations much harder, can make educational situations much harder. It can place huge strain on relationships, not only in your family, with your friends, with your teachers. It can really restrict your life. It can mean that you don't go on camp because it's too difficult. It might mean, for one family that I work with, they never left the city limits, because if they did, it was a huge expedition. They had to have changed their clothes. They had to know exactly where the toilets were. They couldn't be in the car with their child because the smell was too much for them, all those kinds of things. So I think it's really important to really hold in mind the huge impact that toileting difficulties can have on families. Because I often think about when I'm working with families, and you probably do too, almost like it's a bit of a mobile. And if you think about a mobile beyond a child's bed, if you knock one part of the mobile, suddenly the whole thing is moving. And so for one person in the family to have a difficulty with their toileting can impact that whole mobile and destabilise things across the board. This is really, really important to keep in mind. The idea that soiling particularly evokes a really big reaction from parents, from peers, from teachers, and even, I would also argue, from professionals. It is more difficult to deal with for lots of people than lots of other forms of behaviour problems. And actually to the end of the 1800s, so, we're starting... we've come through the Industrial Revolution, where we're at 1900s. Professionals were still recommending really, really harsh corporal punishment for kids who soiled themselves at that time. And I think it's really important to remember that kids with functional enuresis are often shamed, they get blamed, they get punished for having accidents. We know that for parents, it can be incredibly aversive, incredibly aversive, and it invokes parenting styles that can be a bit different than how parents would like to be parenting their kids. We know that these kids are more likely to experience hostility in their relationships than other kids are. And the reason I put this up is just so that we can really hold in mind the emotional punch that toileting difficulties can have on young people and their families. In my experience, toileting difficulties, if I think about the things in my career thus far that have really distressed families, the main ones that seem to be incredibly difficult for people to get their head around are stealing, lying, sexualized behavior, and toileting difficulties. Because it is aversive and it is confronting and it is never ending and it is right there in your face all the time, impacting so much of your life and your relationships. And I think it's really important to keep in mind that, people get revolted by this and they treat these kids differently than they might treat them if they had an anxiety problem, for example, or if they had epilepsy or something like that. It has more of an emotional punch. And to illustrate that, I want to take you through some quotes. These aren't from the literature. These are just things that I've heard time and time again, and you'll have heard them as well. I don't understand why he is doing this to us. And you can hear the attribution in that. He is doing this to us. This is deliberate. This is malicious. We've never been out of the city because it's just too hard. We're too limited by it. I'm at my wit's end. I've tried everything. There is nothing new that you can, there's nothing new. It just won't work. I just can't do this. I'm so tired. I'm so knackered. We've been going at this for so long. We thought it would resolve really quickly. And I should be able to fix this. And that bottom one, I think, is a real source of shame for a lot of people who are supporting the families, supporting these young people. So for parents, everybody else's child shits in the toilet. Why is it that he can't? And why is it I, as a parent, have failed to teach my child to toilet appropriately? I think when we think about toileting and we think about even toilet training, it's a complex process and everybody's got an opinion. When my goddaughter was toilet training, she was later than other people thought she might be. I think she was fully toilet trained at 5. And I received phone calls from people in my family ringing me as the psychologist in the family saying, oh my gosh, I'm so worried about her, people should be doing this, this and this, all these kind of things. And it made me really sit there and think, gosh, everybody has an opinion about this and everybody thinks there's a way that they should be able to find to fix it. And it really made me think about what that must be like to experience, that feeling of failure, that feeling of I should be able to find a way to do this and I haven't been able to do it, and how society really impacts that. So it's really important to keep this emotional punch in mind. And you know what, we're not exempt from it as professionals. When I'm working, in this field, people that you bang into when you're talking around these kids often talk about how frustrating it is, how hopeless they feel for these kids. They've got low expectations around whether families will be able to pick up and run with treatment, really hoping that someone's going to come in with the answer. There's going to be someone with a silver bullet who's going to, whether it's a new medication, whether it's a new strategy, whatever, that's going to save us from the difficulty of working with these families. And I think it's really important to acknowledge that we're not exempt from the emotional punch. We can feel that same stuckness as families do. And we can also get stuck in the same attribution traps, where we attribute people's behaviour incorrectly. We can get into a cycle of blame. We can get into, a situation where we're actually adding to the burden rather than lifting it. And I know this happens very rarely, and I know this probably only happens on our worst days, but I think it's really important if you've got people around you and you're hearing that sort of jaded, stuckness in people's speech. I think it's really, really important that we check in with each other and we provide support and we empathise with each other around the fact that this is really, really challenging work. But we also challenge each other a bit on how we talk about this work and how we hold hope for these families. I've often thought from time to time I will be contacted in private from different professionals, and they'll write me a referral email, and the tone of the email around a child with toileting difficulties can often be really, really different than it would be if they were writing to me about a child with anxiety. Anxiety often makes us feel empathetic and soothy and all those kind of things, and toileting doesn't so much. And I've often reflected on that, how the tone with which we can use can be really different for these families. So I just want to spend some time talking about that with you guys, and just really acknowledge that this is incredibly, incredibly difficult work, and we have got to be aware of how that is working with us, and how we can do that well for ourselves and for families. I'm not going to talk to you about how to treat toileting difficulties. The nuts and bolts of it, we all know. We all know about, regular sits. We all know about the importance of exercise and fluid. We all know about things like double voiding, and making sure that we're doing things that help shrink the bowel in the situations of constipation. What I'm going to talk to you about is that bottom one. We know that there are factors, family factors, societal factors that make these problems stick around for longer. Things like learned helplessness, things like beliefs around how toileting works, things like inconsistency, or really coercive interactions where, you start off all level and a parent makes a request of a child to go to the toilet and the child goes, no, and then it gets louder and all of a sudden it's this huge, big thing, when actually all that happened at the start was a request to go to the toilet. Those sort of coercive interactions and escalation traps, all these things are the things that pour fuel on the fire for these difficulties, and that's where I want to spend my time talking with you around things that might be helpful. So I think one of the really useful things about how to manage toileting difficulties is helping parents get useful facts about what is going on in their child's body. And I think one of the most useful ways to do that is to do things like show videos, or talk them through what it's like for other kids as well. This video I've given you, you can't see my piece. Oh yes, you can. There we go. This is one that I use quite often. It's about 7 minutes long. You've probably seen it before. The reason that I like it is because it goes through and helps. It covers the constipation cycle really, really well. And can be really helpful light bulb moment for professionals, for parents, around what is happening in their child's body. We need to show them material which helps them understand what's happening in their child's body, and often it's happening without the child's control. The most useful way, I think, of conceptualising toileting difficulties are as developmental delay. If we think about something that a child is not yet able to do, can't do yet, rather than won't do yet, you can hear the difference in that. If it's something that they can't do, we tend to approach that with understanding, with compassion, with scaffolding, with teaching. If we think it's something that they're deliberately not doing, we tend to approach that with punishment, frustration, those kind of things. And so conceptualising the toileting difficulty as a developmental delay can be really, really useful. That's not denying the fact that there's often a behavioural component as well, and you're working with the can't and won't together. But understanding more about what's happening in a child's body can help families, correctly attribute what is happening. Down the bottom I've written, useful facts are helpful, scary ones without context aren't. The reason I write that is because often we'll get on a bit of a roll as professionals and we'll start talking about how toileting works, and we'll start talking about, different things we think are helpful. And sometimes we forget that the people we're talking to don't hold the same knowledge as we do around perhaps the research in this area, the latest studies. They might not have had the luxury of speaking with a GP around it just the other day and shooting the breeze over it. And so we've got to be careful that the information that we're giving is developmentally appropriate, is useful, is qualified by context and isn't just unnecessarily scary. To illustrate the point, one piece of information we could give about toileting is that in caprices, 1% there are still a percentage of young people who will have not gained continence by 17. That's a fact. We know it's a fact. The fact in context looks like this. So this, nocturnal enuresis, sorry, not encopresis. So this is a graph from the Royal Children's Hospital in Melbourne, looking at the percentage of kids who have nocturnal enuresis as they get older. So this is the context for that statement. Yes, you'll see there that there is a small proportion of children who at 15 still haven't developed the ability to be continent of urine at night time. But this is the context. Over time, it's dropping. And that percentage who still have it at 15 is pretty low. So I think we've got to be careful that we're giving the information we're giving is complete information with context and isn't sort of unnecessarily alarming. In terms of treatment, I've flipped some references at the end of the slides. You're very welcome to have a look at them later on if you want to. But this is drawing on an article that talks about best practice for treatment for learning difficulties, and peppering some of my own stuff in there too. What we know is that rapport is key with intervention of any kind. You'll know this as well as I do. You might have the best intervention plan in the world at your fingertips. If the families feel like you don't care about them or understand what's going on for them, it's probably going to be useless to you. There's lots of research around what percentage of intervention success can be predicted by relationship versus the intervention itself. In most articles, most studies will suggest that it's about 70-30. It's actually about bringing yourself to that consult. It's about talking with families in a way that, is empowering and supportive and builds relationship. And actually the best intervention in the world can fail if you don't have that relational platform for it. We know that motivation and treatment adherence are big predictors of success. And so we sit there and go, okay, how do we increase that? How do we find out where people's motivation is at the moment? And how do we try and work towards lifting that? One of the most useful approaches, I think, for that is an approach called motivational interviewing, which I'm sure you'll be familiar with as well. The idea with that being helping people understand why it is, having them tell you why it is they want to have a crack at this now and how confident they are that actually they'll be able to have a crack at it. And if they say to you, I'm 80% confident, some people might follow up with the question, oh, why not 100? But actually a better question is, okay, so how come you're 80% confident rather than like 10 or 20 or 30% confident? What's making you feel confident about this? And trying to build on the relationship and build on the motivation, that's already there. We also know that psychoeducation, so like talking about these concepts is really, really important. So that's why we talk about making sure that people are understanding what's happening in their child's body. That's why we'll do things like externalizing the problem. That's why sneaky wee and sneaky poo are so successful. It's because when you can take a problem and go, right, that's what's happening. Sneaky poo is getting in our way here, rather than Jaden, my son, is getting in trouble, is in my way here. It allows people to, it helps preserve relationship, I think, when you externalize a problem. And it also gives the kids an externalized battle to fight. It means that they're not trying, they're working against sneaky poo, which is making their lives difficult. It gives them something to name and a language to talk around it with, which I think is really important. And we know the mechanics of it. We know that we've got to clear constipation, for example, for encopresis. We know that people have to be on laxative medication. We know that time toileting is really useful. I guess a point there is the idea that having rewards paired with toileting behaviour, not necessarily the poo going in the toilet, can be a really useful place to start. It's indelicate, but often I'll talk with families about how deconditioned our bowels can get. And the idea of actually trying to predict when the poo is coming is really, really challenging. An analogy that I use is it's almost like working at a bowling alley in behind the pins. And at some stage, there's going to be a bowling ball come towards you down the chute. and your job is to catch it. Now, you've got no idea when that bowling ball is coming. And so it's about, putting yourself in a position that you could catch the bowling ball if it did come. It's about having some practice at going to the toilet and sitting and doing those kind of things just in case that can get you there. Because often I think if we're waiting to reward these kids for pooing on the toilet, we might be waiting for a long time, but we're wanting to shape up their behaviour so that that's something they're able to manage. And absolutely chuck in a bonus reward if it is they have some success, but it's the behaviour we're trying to shape. And I think that's a really useful way of looking at it. In my experience to date, it's been really challenging to get families to have minimal responses to accidents. And often people will get into something which feels like an inquisition. The child has an accident. The parent said, "Did you feel it? Did you know it was coming? Did you know you should go to the toilet?" Now, in that situation, the child's damned if they say yes, and they're damned if they say no. If they say, "Yep, I knew I needed to go," well, why didn't you? If they say, "No, I had no idea," well, why not? Were you not paying attention? All those kind of things. And what I work with families to understand is that actually that conversation is a waste of time and energy and oxygen. It's a waste of time to try and have those kind of interrogative conversations with our young people, because a lot of the time they do not know the answer. And actually you're sufficiently frustrated at that time that it wouldn't matter what answer they gave. It's not going to be good enough for you. I think it's really important to help people be aware of the wins that they're having, taking the little wins that they're getting, and having some praise around success. Often we know that our brains are designed to attend to problems. We're designed to pay attention to things that need fixing. And if we are tired, if we are cranky, if we are ground down by this stuff, we can completely lose our ability to see the wins that we're getting, and we find ourselves in all or nothing thinking, "Oh, he never goes on the toilet. Oh, he always has an accident before school," those kind of things. So it's about us being able to get in there and notice changes in the narrative, notice little things that have gone positively, and help draw families' attention to those. We've also got to really keep in mind that difficulties can be secondary, not primary, so it's a symptom rather than a cause, and we've talked about that already. It's really important to keep in mind. These ones are mine, and they're ones that I'm sure if you were writing this presentation you'd have come up with as well, because they're the things that are really important in how we build relationships with families and how we can really get these things on the road. The first one up there is helping families build empathy. And I'm not sure whether this is your experience, but it's certainly mine, that often families will come into me having been trying to get some support for toilet difficulties for yonks, absolutely yonks and yonks. And it's almost like they've got to the point of trench warfare, where the child is ducked down in one trench, just trying to survive, and the parent is in another trench just trying to survive. And no one wants to pop their head over the trench, for fear of having it blown off, for fear of there being another problem or something like that. So people tend to sort of duck down and have this sort of parallel interaction, these relationships where, there isn't sort of that seeking for each other anymore. It's about survival. And obviously this is a huge generalisation, and this isn't the case for all families that I work with, and it won't be the same for yours either. But I think often the thing that can go out the window when people get ground down is their ability to be empathetic, our ability to see things from the child and young person's point of view. And I think often what our roles are in this situation is to try and help families understand that actually the experience of not being able to control your own toileting must be incredibly challenging. So we'll have conversations where we'll say things like, "Man, okay, so he had an accident at school. Man, that must have been incredibly difficult. It must be really hard and really scary to have no idea when at some point your tummy's going to explode and suddenly, you've been kicking around a soccer ball and stuff, and then all of a sudden you've got poo running down your leg." That must be incredibly unpredictable and pretty stressful. It must be really confusing if you have trouble managing this, but no one else at school seems to be doing that. Or it must be really frightening if people, if you're concerned that people might find out about this and then alienate you. That must be really scary. So doing things to try and help families link back together and reach for each other, I think, is really, really important. And I've written target attribution error. Attribution error, I'm sure you're probably aware of. I'm sorry if this is egg sucky, but it's around, from time to time, we will make fundamental attribution errors around why something is occurring. We will interpret things from our point of view. And so the biggest attribution error that I see in families that I see is around making attributions that are around deliberate malice, almost as if they feel that their child is sitting in their bedroom going, how am I going to ruin my mum's life today? I know I'll shit myself repeatedly. And I think when we've been ground down and we're in this hostile situation where there's a constant problem, it's very easy to find ourselves blaming, or find ourselves taking shortcuts, or find ourselves seeing malice where it isn't there. And so we need to be careful that we're weighing up what might be causing these difficulties and helping people have accurate responses to that. It's really important to have reasonable and family-informed goals. I'm just going to skip ahead one slide just to hear. The trouble with not having realistic goals is that distance between what you wish was happening and what's actually happening, that space in the middle can be incredibly frustrating when there's a big discrepancy between how you wish things were and how things actually are. Usually the bit in here can be filled with frustration, disappointment, feeling ground down, all those kinds of things. And so this is why it's really important to help people develop realistic expectations. Now, when you look at this diagram here, you can tell that what's going to shrink the frustration arrow is either going to be if reality gets better or expectations come down to meet reality. And the place I like to work in is when we bring the expectations down a bit as well and try and gradually improve their reality. So, you're not expecting that the day after you see me, your child's going to be fully continent for the rest of their lives. It's all about, working out what's a realistic goal here and working towards it. And the other thing I mentioned there was having family-informed goals, having collaborative goals. You'll all know what it's like when people make a decision in your workplaces without consultation and say, right, no, we're doing it this way now. It's incredibly aversive, even for people who have fully developed adult brains, who are in fields like yours and mine, where we are in these fields because we care about people and we try to be accommodating and kind. If something happens and we feel like we're being done to rather than doing something with our organisations or in private practice, that can be really aversive. And I think it's the same if you're a parent working in this kind of situation. You want to be on board, you want to be helping, you want to have the rudder of the ship actually and be helping change the direction and determine the direction that your family's intervention is going to go in. If you're using behavioural interventions, you'll know this too, but it's really important to have an actually decent behavioural currency. The reward you're using has to be actually rewarding, and it has to be sustainable. I'll always remember I've had one 6-year-old try and convince me that she should be given a trip to Disneyland if she stopped stealing food overnight. And I had to sit her down and say, look, I'm really sorry, we need to sell something that mum and dad are going to buy and be able to keep buying. And we had to change our reward. The other thing is, it's important that we don't try and guess what the reward would be, what would be a rewarding reward, sorry, for lack of a better way to say that, because we can get it wrong. And a really key memory for me clinically around this is I was working with a family where there was a lot of violence between adolescent kids and their parents, and it was the kids that were being violent towards the parents. And we were trying to bring in a behavioural contract around how we would treat each other, and what the kids could earn through interacting respectfully and having gentle hands and feet. And I remember this big, burly person in their late teens coming and saying, oh, well, mum used to cook really nice curry, which was my favourite, and she doesn't cook it anymore. And in order to get a curry once a week, that young person stopped hurting their mother. And it really made me think about, the fact that behavioural shaping through consequence is really important. It's really powerful. And it can be a reward you would never have expected might be the thing that gets you over the line. You might find that you, when you're working with families, have people say things like, oh, I shouldn't have to, do a song and dance whenever he, wheezes where he's supposed to, because he should just do that. I don't want to be bribing my kids, those kind of conversations. And quite often what the conversation I'll have there is, yeah, you know what, you don't want to be having to shell out 50 cents every time he wheezes in the toilet when he's 45. And so these things are short-term things that we then phase through. But I'll quite often come back to the fact that I'm more likely to go to work if I get paid. You probably are too. Most of us don't speed on the roads because we are worried we might hurt someone or we might get a fine. The natural consequences of our actions shape our actions. And so I will try and, use that to help people understand how behavioural consequence is really important. And it's not necessarily about bribing or paying your child to go to the toilet or whatever. It's about trying to shape that behaviour. Another pet peeve of mine is the attention-seeking myth. Oh, he's just doing it for attention. And we say that as if attention isn't a valid need. But if you think about it, humans are social beings. If you walk into a lunchroom and you say, oh, g'day, and nobody says anything to you and they ignore you for the entire lunchtime, that would be incredibly socially threatening, really, really aversive. We need to be seen and understood by the people around us. It's a need, not a want. And so I think it's really important that if people come at it from an attention-seeking kind of point of view, that we're able to go, okay, so maybe that's a need that he has, he wants to interact with you. How can we meet that need? Because actually that's a really valid need. I think if we view someone as an attention seeker, we tend to think that they're just being annoying or being unreasonable, that their need isn't valid. So I think I'd often work to try and manage that too. I've got tag team parenting on here because often, and you may find this in your work as well, you will have one parent sometimes who will be the person who's been leading the toileting charge for a really, really long time, and they are knackered, but they're also really unwilling to pass the mantle to their partner or to anybody else because they feel concerned that it won't work. It's really important if we can support parents too to do these things together in concert, working together. And if that means that actually mum's getting too head up, dad comes in and drives it for a while, because we're pacing for the marathon, we're not pacing for a sprint. And I think that's another really important piece of information to get across to families, is that actually the toileting difficulties are going to take time to resolve. And so they have to have a sustainable intervention, and they have to have a sustainable level of wellness of their own to be able to try and keep that moving. Self-care is at the bottom of the list because of my point before about trench warfare. Toileting difficulties pack the emotional punch we've already discussed, and they can really get people on the ropes. And we know that our fuses are shorter when we are tired. We know that our fuses are shorter when we are feeling, like we're not going to get anywhere, all those kind of things. And so I will spend a lot of time with my families talking about how they can look after each other and pace for that marathon rather than for the sprint. So I want to take you through some of the cases, and these are conglomerate cases. These aren't particular kids that I've worked with, but I want to give you some examples of some themes that have come through in my practice so far and might resonate with yours. I'm thinking about a 17-year-old who came through my clinic, and she had been having constipation and toileting difficulties her whole life. She'd never had a period of continence at 17. And the family were at their wits' end. I remember they came in to meet with me, and from the minute I met them, I could tell mum was coming in swinging. Mum was coming in, and it was really important for her to tell me that they had tried everything. They had worked really hard to manage this. And, the kind of implication was, you don't have anything new to tell me because I've been here before, this is a waste of my time. But at the same time, they wanted to be, there was enough to get them in the room, and they wanted to make a difference to what was happening for their daughter. Interestingly, for that young person, they went to a school where there was going to be a trip coming up at the end of the year, and they were going to be going overseas. And there was a real natural consequence there because the parents had said, look, if we're not getting on top of this, we can't have you go because we can't afford for you and one of us to go as your carer. So it's kind of make or break here. Like we've got 8 months to work on this, and if we crack it, brilliant, you can go. And if we don't, then we're not going to be able to. And so it really became apparent to me it was going to be really, really gently with this family. There was so much defensiveness around we've already tried everything, and and it was going to be about, it was really clear to me in the first 10 minutes of my consultation that I was going to be spending a lot of time with my mouth shut and my ears open, because actually it was about letting them tell their story of how they'd got to where they were, where they wanted to be, how frustrating it had been to get there. And, and as they talked, I realised this was about a deep love for their daughter, that they didn't want her put through the ringer again for an intervention that wouldn't work. One of the useful things about the person I'm thinking of was she was very scientific in her thinking. And so we talked about what her theories were about what was happening. We talked about having a toileting diary, and she monitored it. She made an Excel spreadsheet. She monitored it down just to the umpteenth detail, and she really picked it up and ran with that. And it was actually going back to the fundamental concepts around toileting, why it is we take laxatives, why that's important in terms of helping reduce soiling, all those kind of things. Things that I learned through this family was, one of the things that was really obvious at the start was they were completely ground down, and they had got to a point where they had reached an acceptance that this was how life was going to be. Their daughter would have 6 or 7 poo accidents every day. She'd stick her soiled undies in the bin in the laundry. Mum would sort them out, and they just go about their business. They'd completely restricted their lives so that they didn't have her in a position where she might poo herself in the car, for example. And just the incredible amount of restriction on this family was incredible. And actually through returning, through that non-judgmental, gently returning to, really fundamental toileting concepts, we got her there. And she was able to reduce her soiling over time. And as her soiling reduced, I watched Mum's buy-in increase to the point that when Mum left, she, I'm thinking about, there was one person I've worked with who cried as she left and gave me a hug as she finished her treatment. She went from this person who had been swinging from the get-go to someone who gave me, was in tears as we finished, and just so grateful and so pleased that they had managed to make a change. So my learning through that case, all is not lost at 17. It was really nice to have a case where we were able to make some moves at that time. And it was really important for me to be authentic and just go with the family, pace with them, listen to them first. It was really useful to have that natural reward and the natural consequence of the trip at the end of the year. And really important to go slowly and get the buy-in of the family in terms of the treatment plan, and help them understand that actually I could hold the hope for them, and over time they would hold it too. And I think that we have a role to play with these families as hope holders, because a lot of the time it's difficult to hold on to hope when things are continuing to go poorly. So those are things that I learned through that case. Another example, 6-year-old girl, really strong health anxiety. She had developed constipation following a surgery where she wasn't able to eat for a while afterwards, and later required disimpaction. And the whole hospitalisation was really, really difficult for her. And what was really clear was that her parents were incredibly anxious that she might get bunged up again and need to go to hospital again, and that was an incredibly challenging thing for them. Over time, it became really apparent that one of the primary drivers here, when we think about comorbidities, was there was that health anxiety there, but it was also maternal anxiety that was really fueling the fire for this young person. And so it was around sitting with Mum and looking at her responses around toileting, going through the information, the concepts we've discussed already about how you can write things if things aren't going well. And it was actually about being able to support that whole family system. It was about getting in there and supporting Mum with her anxiety, getting Dad on board because he was a bit more level-headed, he was a bit calmer. And, getting them both on board and looking at how when they changed their responses to their child's anxiety, the child's anxiety dropped. And all of a sudden, the fear of toileting wasn't there so much. So I want to share with you the anxiety cycle. This is something that I use a lot in my work, and it can be useful. It's stuff we intrinsically know, but it can sometimes be useful to have diagram like this to work with families around. You can take them through it, and you can go from this first bit up here. The situation arises. So for this child, the situation was they had pain in their tummy, for example, and they didn't want to go to the toilet. And they felt really anxious whenever they had a fart or whenever they felt something change in their tummy. And so then mum and dad would see them behaving anxiously. They'd see, tears, withdrawal. They might see exacerbation in behaviour, all those kinds of things. And the parent's response there was that the parent felt incredibly anxious and just wanted to save. As we do, we're designed to save and love in the face of anxiety. And so what would happen there would be the parent would do things to try and, save the child from having the difficulty. So she might look into distraction or things like that, trying to get them to not go to the toilet. And when the thing that we fear goes away, for whatever reason, for example, if you think about a child who might be brought into hospital for a disinfection, the parent decides not to do it, the child immediately feels incredibly relieved because the anxiety, the stressor is gone. The parent feels relieved because, thank God, we're not going to have to go through that. But then often we find ourselves thinking, oh no, that's going to be a lot harder to shape up going forward. And it's this bit here at the top of the diagram that's really important. There are two things that are important to note in this diagram. One, the parent is going to be the person who leads any change to the dance around anxiety. And it's actually the parent's move that's going to determine the rest of that cycle. If they choose to stay in a situation and push the child through it and support them through it. So it's not just shoving them off the deep end. It's supporting children to do things they're frightened of. And they have different learnings they pick up through managing to have some success with that. If you've been very frightened, for example, about going to camp and managing your toileting there, and so parents put in plans to try and support you to do that, you go to camp and you manage it. You learn in that situation, okay, I can do this. Mum and dad are going to back me to do this. I can put things in place to try and make this manageable. Whereas if you decide, oh no, I'm not going to go to camp because it's too hard, or mum and dad pull the pin or something like that, the learning can be quite different there. This must be really hard for me if mum and dad aren't allowing me to do it. All those kinds of things. Now, it's reductionist because sometimes avoidance is actually, it's about picking your battles, and sometimes I absolutely back people to avoid things which are going to be too much for their children, or chunk it down to manageable goals. But it's important to keep the anxiety cycle in mind, because when the parent in this situation was responding with more anxiety than the child had felt originally, that was really inflaming the situation. And you can see it a lot in toileting difficulties. Learnings from that case, psychoeducation, learning what was happening in the body was really important, and actually having wraparound intervention that was able to go, okay, anxiety is a primary driver here, let's address the anxiety. And I know that's different for us with different professional backgrounds or different places that we're working. But in that situation, the thing that was going to cause the change was supporting mum. And I think we're all trying to work out what the blocks are to being able to manage toileting well. And if you notice one that doesn't sit with your service, it's about being able to try and facilitate the removal or the shifting or the shrinking of that block. Another one I found with this one was the usefulness of check-in. It was difficult for this family to let go of me at the end of our intervention. And so I said, look, you've got my email address. If you need me in the future, just get in touch. And a year and a half later, she came back to me and said, oh, it's all gone to hell in a handbasket. And all it took from me was a 10-minute email of reminding her what she already knew, and she was away. The bottom one, what we say isn't necessarily what people hear. The importance of checking understanding with people that you're talking to. This family that I'm holding in mind, we talked about the idea of blowing up a balloon on the toilet because that would try and get the muscles pushing, and that might be helpful. And Dad misunderstood this. And so Dad, I got a phone call, I got a photo a while back from a family of this toilet just completely covered in balloons, just balloons everywhere. And what they had understood was every time they went to the toilet, they got to blow up a balloon, which they then left in the toilet. And so you could just see this little tiny toilet in the bottom of this huge big picture of balloons. I thought I'd been really clear around why we were using the balloons. They completely picked that up in a different way and run with it. So it's really important to check understanding. Last case, just briefly, a child separated parents. Sorry, I've got a typo there. It was a young boy whose mum and dad were separated. had regular wedding accidents. It was secondary enuresis. He didn't soil at school, and he seemed to be able to pee for a ward. So if Dad said, actually, we need to go, we're going to go to McDonald's and you can come with us if you do your toileting before you go, he was able to do that. Throughout the referral that I'd got and how things were looking, it was really clear that he seemed younger than he was. But developmentally, he was functioning at a lower level. And over time, it became really clear that his family situation had contributed to that a lot. Actually, he had developed the ability to toilet. Then when Mum and Dad had separated, he had lost it again. And he had got to the point where actually Mum and Dad were wiping his bum and helping him get dressed and undressed, all those kinds of things. And I think we worked through that and worked through understanding what it was like for him to have Mum and Dad that had separated. It was a situation where one parent was incredibly onto it and had, great routines in place and all those kind of things. And when he went to the other parent's house, the laxative medication didn't get given. He didn't have a SIP practice because things were more chaotic in that situation. So in that situation, I was suddenly going, okay, what I'm working with is one half of the family we're going to be able to make a lot of change, another half of the family we're going to need a lot more support. And over time, it was working out how are we going to bridge that gap as over time it became apparent that it was going to be that gap in one parent's house. When I went through that case was the importance of family factors and being straight up. Things weren't going to move unless that consistency was going to be able to be there. And I was able to have that conversation with the parent who was experiencing more chaos. And we were able to make some decisions, like the child would have his laxative medication at school instead of at home, to be able to keep that consistency even though he was going between these two quite different family environments. It helped me understand the difficulty of working across contexts, which I'm sure we all encounter, and the usefulness of high health needs, funding and support at school. We were able to get the laxatives given at school, regular toileting happen at school, regular toileting was happening at one parent's house, and that I think will slowly over time try and pull the overall toileting in a positive direction. I think it was also important to know that with it being secondary, how did we support this young person about his family breakup, which he was really struggling with. For me, I was able to do that myself. For you and your service, it might be about finding somewhere to refer him for that, which is really important. So hey, just to finish off as my voice starts to give out on me, takeaways from today's presentation, it is all about relationship working with these families. You'll know that, I know that, but it's still a useful reminder. You can have the best intervention plan in the world, but you have to have relationship to base it on. It's really important to cast your net wide in terms of what might be happening for a family and influencing the toileting behaviours that you're seeing. We've talked about comorbidities today, how often it is that there is something else going on for a family beyond what you have seen. And it's really important to let go of our expectations of simplicity, the idea that there will be this really simple toileting case. We can't be, I think if we are prepared for complexity, it doesn't surprise us and bring us up short quite so much. But it's important to understand that chances are, when we get a toileting referral, we're walking into a fairly complex situation. It's really important to support the whole family system or find ways to do that. It might be that in your role, you're able to do that. You're able to do the whole thing yourself. It might be that you have to get support around looking into things like behaviour, ADHD, parenting, all those kinds of things. But what we know is we stand a better chance to manage this when we are supporting the whole family. Other things I'd add to this, check that attribution, build that empathy. Often I'll say with families, you know what, I know that this is more than you guys just flicking a switch to turn it off. Because actually, if your child was able to stop this from happening, bam, he would already have flipped the switch years ago. It's more complicated than that. We've got to help families develop their knowledge of what is going on. Something that you might throw in is the idea of, something that's just come to mind is the idea of olfactory adaptation. People will say to me, can't he tell he stinks? And I'll say, well, no, he probably can't, because his nose has adapted to manage it. The same way if you've had a history of smoking, you won't have been able to smell the smoke on yourself. He probably can't smell the poo on himself either. So helping just give those little important pieces of information can be really helpful. And finally, the thing I want to leave you with is we need to acknowledge the punch on families, but also on ourselves. This is complex, difficult work, and we can fall into that stuckness that the families are in. I think it's really important to look after ourselves. All these things that we suggest our families do to support themselves, we have to do as well. And we've got to keep an eye out for our colleagues and, hold hope for each other when we need to. So, hey, that's what I've prepared today. There's some references here if you need them. Thanks so much for listening. I hope it's been helpful. And yeah, I just wish you all the best in your work. It's important work and it's hard work, but it's also really, really valuable work. And so, yeah, I wish you all the best with it.